Welcome to the Motion Lab, the podcast that explores the science of movement and helps you live a stronger and healthier life.
Welcome back to the Motion Lab podcast. My name's Chuck Dowell. I'm one of the PAs here at Colorado Springs Orthopaedic Group. Today, I have the pleasure of talking to Dr. Friedman.
I'm Dr. Jamie Friedman. I'm one of our sports specialists here at CSOG, and we're going to talk about cartilage restoration.
That's right. It's kind of one of your passions, right? Cartilage restorations, and it's a growing topic, and so we thought it'd be good to have a conversation regarding it. Let's first kind of talk about cartilage. We have different types of cartilage in the knees. Can you explain that briefly?
Cartilage in the knee is articular cartilage or hyaline cartilage, and it's specifically meant to help with smooth gliding of the articular surface or a joint surface, as well as provide some cushion to a joint, which helps our joints function properly.
And it's kind of the protective cartilage in the knee, right? So it's kind of those smooth gliding surface of the knee. We have other cartilage. Meniscus is a form of cartilage, and there's other types, but the specific cartilage we're talking about is that articular or hyaline cartilage.
Exactly.
And so some patients can have damage to the cartilage, whether it be trauma-related or, congenital related, and you specialize in fixating those cartilage-damaged areas, correct?
Yeah.
So why is the articular cartilage important? Why is this such an important structure that we're trying to do specific surgeries on?
Yeah, so cartilage is super important for joint function and keeping it going. But if it's injured, it doesn't have a good blood supply. Yeah. So it doesn't heal on its own, which can be detrimental over time or even in the acute phase. A cartilage injury can cause pain, swelling, loss of function to a patient. And over time, it can just get worse and worse. And like you said, there are kind of two types of cartilage injuries. There's an acute injury, usually a younger patient, teens, 20s, 30s, 40s. And then there's another type of cartilage injury, which is just osteoarthritis. That's over time. It's degenerative. It loses kind of its healthy components. And so we see it deteriorates over time. You drive your car long enough, you're going to wear the tread of the tires out a little bit.
Correct.
So that's the different kind of cartilage that we're talking, or different kind of treatment that we would be talking about rather than cartilage restoration.
And that's, I think that leads into the next, who would be a candidate for this cartilage restoration surgery? So patients that have diffuse articular cartilage wear, wearing down on that cartilage, but more diffuse wear, probably not a candidate, right?
Not a great candidate for cartilage restoration.
Yeah.
Then you're talking about, certainly there are conservative management options for those patients, whether it be, rest, ice, anti-inflammatories, even injection options, or surgery like a knee replacement. But the ones we're talking about are kind of those younger, healthy, still very active patients, like I said, kind of teens, 20s, 30s, even 40s, that had a single sort of specific cartilage injury or one specific defect rather than diffuse cartilage loss throughout their knee.
Yeah, so our terminology is focal chondral defect, right? So
Yeah.
we were talking about this beforehand, and an analogy, which we both had the same analogy, I think, taught to us, is a pothole in the road.
Mm-hmm.
So, if you have a sinkhole or the whole road is bad, we can't fix the whole road. We can repave it, but that's a knee replacement. If a pothole in the road is missing, then you can do a cartilage restoration procedure to maybe fix that lost pothole or that small focal defect, correct?
Exactly, yeah.
And a lot of these are younger patients that have maybe traumatic injuries. Mm-hmm. So there's a couple different ways that we can fix that, or you can fix that. You can do cell-based, where you fix just the cartilage itself, and then if the bone underneath is affected, that's a different procedure.
Yeah.
What are the different procedures you do to fix the cartilage defects?
Yeah. So the first ways I think of this are, like you said, is it just a surface type of procedure? Then you can think of things like, first off, just debriding it, right? Mm-hmm. That's not restoration, but that is part of surgery, minimally invasive. But if we're restoring it, you might put cells in there. Mm-hmm. Some of the cells, the companies might call them biocartilage, BioArthrex, or de novo by Zimmer. But you're basically pasting juvenile particulated cells. So they know they're supposed to be cartilage. They just haven't grown all the way to be there yet. And you paste them into their place, and then they get those signals and they grow into cartilage. But that will only do the surface, mm-hmm. right? Another surface procedure, if it's a little larger, because that's only for 2 centimeters squared, so smaller defects, If it's larger, then we think of things like MACI.
Mm-hmm.
MACI is matrix autologous chondrocyte implantation, MACI, where you actually take a sample of the patient's cartilage, send it to a lab, and then they grow their cartilage into basically a sheet of cartilage, and you paste that into the defect. But those are only for those surface lesions.
Yeah.
If we get deeper, there's subchondral edema or cystic changes, then a surface procedure won't work. It's like putting sand in your pothole.
Yeah.
It's going to go away over time.
Yeah.
We need something structural to fix that pothole. Then we think of things like osteochondral autograft or allograft, where we take it from the patient or a donor and put it in almost like a plug.
Yeah. To fill the defect.
Exactly.
And the slight difference between the surface procedures, talking about those first, the biocartilage, just so everybody knows, is allograft, so cadaver tissue, and it's acting as a scaffold to kind of allow new cartilage to grow in there that we hope is not as good as what we're born with, but something that can withstand the wear and tear of the years of movement in that patient. Is that correct?
Yeah.
And one of the benefits is you can do that as a single procedure. So it's a one-time surgery. They don't have to come back for that.
Correct. Whereas MACI, it's 2 stages. Exactly.
So MACI is one of those, and correct me if I'm wrong, we're in there doing surgery for potentially something else. We see a cartilage defect. We take a graft at that time, and if that cartilage defect becomes symptomatic, we can go back in and do that later, or we can schedule a surgery later. How long does it take for the lab to grow that cartilage typically?
Typically 4 to 6 weeks, although if you're really under time crunch, you're doing it with another procedure. Sometimes we can get it a little faster, but what's really cool is the MACI company will actually freeze your cells for up to 5 years with no cost to the patient.
Nice.
So if you say, listen, this is not a good time, save my cells, but I'm going to come back in the winter when it's easier for me, that's okay to do, and you can actually delay a little bit.
So if you see a patient and you're doing an arthroscopy on them for maybe a meniscal and you see a cartilage defect at that time, you can take the graft, and then again, if later 3-4 years from now that cartilage defect becomes maybe the problem or the source of the pain, you can then potentially do the surgery then, which is a benefit as well.
Yeah, and the cartilage you're taking is not essential cartilage. Correct. You're taking it from usually inside the notch or kind of on the very edge where it's not articulating with the rest of the joint. So it's kind of like no harm, no foul. You take this cartilage now, bank it, and see if it's a problem later.
And we briefly mentioned this. The patients that are typically good candidates for this particular 2 procedures we're talking about are the surface defects, just cartilage defects. There are size implications, correct? So the biocartilage has to be a certain size, kind of a small pothole versus the MACI you can do. What's the limitations on that?
Those can be pretty big.
Pretty big?
Yeah.
What about patient-specific factors? So age, BMI, location of the defect. What are your specific criteria for that?
So we can fix pretty much any location. Femoral condyles, so the bottom of the femur, the thigh bone, and patella or trochlea, which is also the end of the thigh bone, are easier and certainly more predictable than the tibial plateau, which is the top of the shin bone. But certainly you can do these procedures anywhere.
Yeah.
The ideal patients are the ones that are young, healthy, good BMI, not smoker, they're active, they're athletes, they really want to get back to whatever they love doing.
So definitely an age predictor, not really a gender predictor. Men and women can both have the same success with it. Alignment maybe is a little bit of an issue, right? If somebody's more bow-legged or knock-kneed and they put more wear and tear in certain parts of the knee, we may have to correct that as well as do the cartilage procedure. So that's definitely something to take in consideration.
That's a great point, because anytime I do cartilage restoration, a lot of times we'll do an alignment film. So everybody's got some knock-kneed or bow-legged to them, or even what we call kind of a shifted patella. Maybe their kneecap is over one way, and it's going to wear out that side of the kneecap. If you do one of these cartilage restorations and neglect the alignment, you could set them up for failure.
Yeah.
So sometimes these cartilage restoration procedures are coupled with a correction of the alignment too.
Yeah. Because if I'm knock-kneed, I'm going to put more wear and tear on the outside part of my knee. And yes, I can go and fix the cartilage, but if I'm putting more wear and tear on that side, then it may not be as successful. If I can straighten out and, divide the wear and tear to both sides of the knee, the inside and the outside, they'll do a lot better. And then the opposite for bow-leggedness. And so it's important to correct that as well. And then when we go to the second procedure, so if somebody comes in and they have a defect and there's bone involvement, then we're taking a plug from a cadaver or themselves, depending on the size, and we're putting that into, the location where that's involved. That's correct?
Yeah. And so we'll take a measurement, and sometimes that is a 2-stage procedure as well. I go in there arthroscopically, simply take measurements, kind of make sure I can access that defect and come up with a surgical plan.
Yeah.
And then we come back later and we will get a graft that matches them based on their MRI imaging. So we have the right contour and sizes and so forth, and then put that graft into them. So that's also a very predictable procedure and does really well because you give them the structure.
And the natural question I think you get, and when I was doing a lot of this, I would get is it's somebody else's tissue. Like, what's the safety factor with that?
Yep.
What do you typically tell patients regarding that, the safety of having somebody else's tissue in you?
So it is donor and it is fresh donor. So it's not frozen, but it is tested. So they test for all the kinds of diseases and infections, and it goes through quite a rigorous kind of testing panel before it's even sent to me to inspect.
Yeah.
Then it goes through inspections from the company, and it goes through an inspection by myself to make sure that the graft looks good, it doesn't have any issues, and it's healthy for implantation. So it's a pretty rigorous kind of planning that we do to make sure it's safe. The way I tell patients is think of this as kind of you're getting more of a structural graft than really like someone else's tissue.
Yeah.
Because your cells are going to grow into that tissue and it will become yours.
Yeah. So there's nothing's 100%. We can't say 100% there's no risk of disease, but it goes through multiple testing phases where the risk is beyond low.
Yeah.
And there's none of their DNA that's going to get into your system. None of that's going to be transmissible through this graft. Like you said, it's a scaffolding, a structure that your cells will grow into and it will make it their own. That's the goal.
Yeah. And this isn't, some people ask me about rejection. The chance of rejection is so incredibly rare. We do not put patients on any immunosuppressants like you might think of an organ transplant or anything like that. So you don't need any extra antibiotics or medications that you would otherwise need for like some other transplantation. So
that makes sense. Yeah. And so we've talked about the different types of procedures and the different types of potential defects and locations. What about recovery? What's the expectations that patients can have afterwards? Are they walking on it, not walking on it, brace, no brace?
Yeah, it depends on where the lesion is. So if it's on the kneecap or the patella or the trochlea, I let them weight bear right away. That's not a weight-bearing part of the joint. It's more on the side or shear in the front. But they'll be in a brace, and we kind of lock them just in the beginning, kind of like a peg leg pirate, but you can put weight on it. And then we open them up 0 to 30 degrees, 0 to 60, and so forth, and get their motion back. If it's on the condyle, that's a little bit more of a recovery. So we won't let them put full weight on it right away. We'll limit the weight bearing a little bit using crutches, but still able to start moving it quite quickly. Again, we do that kind of graded 0 to 30, 0 to 60, and so forth. Our goal is full function. My job is to keep people active, not take activities away. So we get them there. But some of the milestones people ask me about are, when can I run again? Typically, I let my patients run about 3 months after surgery.
For both?
For both.
Nice. For
pivoting and twisting, skiing, playing basketball, soccer, things like that, that's going to be a little later, maybe 4 or 6 months or so forth. But we just kind of go by milestone. After we know the graft is healed, then we go on milestone, not timeline, and see how the patient does.
And so in general, I would get back to all my activities. My lifestyle is returned 6-ish months, 8 months, somewhere in there.
Somewhere around 6 months for most people.
Just kind of depends on how they're doing, if they're having symptoms with activities, any pain, anything like that. And as you said, in that patella and trochlea, it's nice that they can walk on it. Patients are a lot happier with that, but their leg is locked out straight. So they're kind of pirate peg legging it. But that's better than nothing. And then physical therapy is usually associated with it, right? To get the motion going.
Yeah, critical. Physical therapy is a must after these surgeries. I mean, they'll get your range of motion back, they'll get your strength back, and they'll do it safely. So I tell my patients, You're going to get out what you put in. You put the hard work in, you listen to your therapist, you're going to do well. And again, we go on milestones. So if they're making great strides around 2-3 months, we might push them to go further and further. So everybody's a little bit different. We kind of play it by ear. We have them follow up routinely with me to see how they're doing and adjust their program as needed.
And we don't need necessarily imaging to like confirm graft incorporation unless they're having any symptoms. You don't routinely get MRIs on everybody, do you?
Not MRIs. On osteochondral allografts, I will get an X-ray.
Okay.
Just to see how that bone plug is incorporating into their own.
Mhm.
We do that for just a couple of the first visits, and then once we know it's healed, we don't get anything else.
And in general, I know this is a hard question to answer. What's the success rate? Like what percentage of the patients do well get back to their normal lifestyle? And, in general, it's hard to say.
In general, yeah, it's kind of all over the board in the
Yeah.
literature and depending on your activity, and every human on this earth is unique. But I would say anecdotally anyway, 95+% of my patients get back to what they love to do within that 6-month time frame.
Nice.
There are a couple that lag. There are some that get back sooner, but most patients do really well. But I'm also super selective.
Yeah.
So I choose patients that are right for this surgery who I know are going to do well. You're right. You don't want to pick the wrong person
Correct.
and set them up for failure.
Yeah,
So.
correct. And so majority, 95+%, that's amazing, get back. What's the long-term risk? Am I going to have a defect in the future? Is this going to increase my risk of arthritis in the future? What's the literature show as far as 15, 20 years? We haven't really been doing it for that long, I don't think.
No, it's pretty new.
Yeah.
So the goal of this is to restore the cartilage, and hopefully, if done right and rehabbed well, you don't really have long-term effects, right?
Yes.
I mean, that's in the perfect world. That's not always the case. Once cartilage is damaged, there are things we can't see on MRI or in a scope or even with our own eyes happening to the surrounding cartilage or that area. So could there be some damage that rears its ugly head down the road 5-10 years later? Maybe.
Mhm.
But we do the best that we can now to try and prevent things like total knee replacement in young people.
Yes, correct. Prevent the progressive wear of the articular cartilage, or, that pothole becoming bigger, like the potholes around here in Colorado gradually get bigger. And then having a defect you can't fix. And then that goes on to needing a total knee replacement. So it's amazing technology. It's really cool. I love when you show me the pictures of the patients and it's interesting stuff. And now that we have all these different ways to do it, it's a growing field for sure.
Yeah. I think one of the really cool procedures we didn't talk about is it's very new.
Mhm.
I've been doing it for, I think, 4 or 5 years now. And I think I'm still the only person in the state doing this. Not that it's a difficult procedure in my mind, but it's just very new, is we actually do a complete patella resurfacing.
Nice.
And
Yeah, I was
so
thinking about that.
we'll take off the entire cartilage surface of the kneecap and we'll put a donor on top. And it's similar to like a patellofemoral joint replacement, but no metal or plastic. It's just cartilage. And those people have been doing fantastic.
That's
So
amazing.
it's a really cool procedure with, so far, knock on wood, great outcomes. And we're really excited that it's still, it's always evolving, right? Like this is always new things are coming out. And we're getting better at doing them and providing more things for our patients. So it's super exciting.
And those are probably patients that have patella defects, but they're a little bit too diffuse. They maybe don't have the perfect margins for these cartilage restoration procedures, but we still have a non-metal and plastic procedure that we can give them, which is exciting.
Yeah.
And you have something else going on. I wanted to mention the Perry Initiative. This is amazing. So can you tell us more about that?
Yeah. So this is our first time bringing it to Colorado Springs. It's been done around the country for years, but it's a program for young females in high school to come see what it's like to be an orthopedic surgeon or engineer for a day. It's really awesome. They come and we have modules where they're learning how to do arthroscopy. They're learning how to suture. They're doing an ACL with sawbones, which are kind of like bone-like material, or putting on pleats and screws. And then we have presenters and kind of show them that you can be a female orthopedic surgeon and be successful. And then there's also engineering, which is underrepresented by females too. So we have some engineers come in and kind of tell us what they do.
We talked about this. I think engineering and carpentry and orthopedics all kind of go together.
For
They're all
sure.
part of the same thought process. So if somebody was interested in that, high school age kid, what's the age requirements for that?
They just have to be going into high school this fall.
Okay.
Yep.
And then is there a website, someplace they can look up?
So they can look at our website,
Yeah.
so csog.net. They can also look at perryinitiative.org and just look up our event. Our event is June 6th. And applications, because the kids have to apply, are due the applications are due May 5th.
Look up the Perry Initiative if you're a high school aged female and you're interested in this. And it's super cool. They get a lot of hands-on stuff, and they get if they want pig's feet, they can sew some pig's feet up, or they have, fake stuff. And if they want, to put some plates and screws in like an orthopedist, they can do that.
Yeah.
It's super cool. Where is it? Where's it done?
It'll be at the Arthrex Learning Center off Research Parkway.
Nice. Someplace in
And
town.
it's kind of a whole day, and we have lunch, and it's really fun and
Awesome.
laid back, and it's a great experience. And this is our first year, but hopefully we plan to do this every year. So if they don't get in this year, that's okay. We can do it again next year. And
if they're interested in medicine or engineering, that you'll be there. There'll be a lot of role models there that they can talk to about how they can pursue that career, what type of degree they may need, what classes they can take, and things like that. So it's a great opportunity for those individuals.
yeah, it'll be fun.
And regarding the cartilage restoration, we mentioned this briefly. If somebody is interested in that, how can they learn more about it or see you to see if they're a candidate for it?
So I'm happy to see anybody and discuss it. They can make an appointment with me. Call CSOG at 719-632-7669. Just ask for Dr. Friedman, and we can get you in and discuss it further. Sometimes, it's just an initial visit. We'll get some x-rays, maybe an MRI, and kind of go from there, right? And talk about options, right?
Yeah.
They can also go to our website to schedule an appointment. And they can even see some videos on my website, which is jamiefriedmanmd.com.
And that'll kind of show them some makeshift models of what the procedures look like.
Exactly.
Amazing. Well, very cool. Thank you for joining us today. I appreciated you coming on the podcast. Hopefully we can talk more in the future and see how your patients are doing and how the Perry Initiative event went.
All right. Thanks for having me, Chuck.